My name is Maria Cheshire and I'm a Senior Research Fellow at Swansea Centre for Health Economics. I'm a former sort of staff member of CADA and a friend of CADA. I've been involved with CADA for many, many years, and I recently went over to the Swansea Centre for Health Economics to complete the DISC research project, which I'm going to talk to you about today. My research is based on unpaid care, so unpaid carers, and I'm interested in all aspects of unpaid care, but particularly how unpaid care intersects with ageing, gender, and social care. So I'm going to talk to you today about a research project called the Drive-in Innovation in Dementia and Dementia Social Care, the DISC research project, the role of social enterprise organisations. And just to say that this project was supported financially by a grant from HEFQ, which is the Higher Education Funding Council for Wales. It was also supported by CADA, and I actually worked in partnership with the Dementia Hub, a charitable organisation here in Swansea. And this paper and presentation has been prepared alongside my co-author Abby Davis, who works at the Dementia Hub in Swansea. So just checking in, are there any questions or anything I need to attend to before we go on? I don't hear anything. Okay, so just to give you a broad overview of what's going to be said today in the presentation. So I will start by giving you some context, so why this research on unpaid carers is important. So for the past six years, I've been working on unpaid carers and the idea of well-being. And I'm going to be drawing upon some of that research on carer well-being, and also connecting it to some of the broader issues around the care crisis, and then particularly bringing it into the current project that I'm working on, which is focused on the issues around care market failure. So that's the broader problem that I'm trying to address in this research. And then I'll talk about the project that I'm working on now, which is the DISC project, and give you some of the pilot findings which emerged with the work that I did with the Dementia Hub, go through some of the implications and discuss some of these findings, and then also indicate what I'm currently doing in the bigger project, DISC 2. And then hopefully we'll have plenty of time for questions and answers, questions and discussion, not necessarily always answers. So I really hope that we can get some lively Q&A going on, and please do, I really like it if people can follow up with me in either private meetings or emails. Any questions, if you're really interested in the project, I'd love to hear from you. Okay, so to begin, I always like to start with some definitions, and I know probably there's quite a number of you in the chat or in the webinar who already have a firm idea of who we are talking about when we talk about carers. So the term is often used interchangeably with all these different terms which I've put up here, and there's many more, I'm sure. And I think it's really important that we sort of acknowledge that this, that the term is reflective of and shaped by the different social, cultural and political factors. So, for example, in Asian countries, it's legally enforced that children care for their parents as they require it, as if they when they age. And that's all sort of part, and that's enforced within these filial support laws, and is embedded within the broader sort of religious and cultural context. But in the UK, we don't have filial support laws, but we do have policy a recognition of the term carer, and we often see it alongside in policy unpaid carer or family carer. And I've put the definition up here, that's often sort of broadly seen. And then my work is also responding to issues relating to long-term care, and that is support that is needed by people as they get older. And that's a really broad term, but we know that long-term care is a key and crucial issue for many people, and so how society and policymakers address concerns care also has really important policy imperatives, because most long-term care is provided in the community by unpaid carers. And then finally, across Europe, 80% of all care is provided by unpaid carers, and that's 10% of the population in the UK, and that's according to a Eurocarers survey conducted recently. And then I think is another really important aspect to unpaid care is recognising the gendered nature of care. And because of the nature of care is often considered, it's often across all cultures considered to be women's work, and it's often, that invisible second shift or invisible labour that we really have to, if we're going to be able to tackle gender equality, then we have to be able to tackle issues relating to unpaid care, and those issues are closely tied and connected. And at sort of international levels, UN and other international bodies recognise the importance of understanding unpaid care from a gendered perspective. And then finally, what is important to note within all of this is that unpaid carers experience worse health and wellbeing outcomes, and that's across all sorts of different domains. So often it's subjective wellbeing outcomes are reported, stress, anxiety, sleep deprivation. Health is obviously related to sleep deprivations, and then finances, and then social connections and networks. All of these things can be severely and negatively impacted because of someone's caring responsibilities. And it's not to say always, and that everyone will experience negative wellbeing outcomes, but there's been a huge body of empirical literature that documents how carers can be adversely affected. So my research is located within the problem of the so-called care crisis. And really, what does the care crisis mean? And it was first coined by Hochschild in 1995. And really, it refers to the issues that care needs are growing and becoming more complex. So there's an increase in demand, and there's a complexity in that demand. And there's significant evidence of unmet need and strain, and that's part of this broader narrative that refers to the care crisis. And this care crisis is sort of situated within a backdrop that, yes, is related to increasing life expectancy and aging population, but there's so many other things that are, at play here. And as a gerontologist, as a social gerontologist, I'm interested in the social aspects of aging, and always interested in sort of understanding why certain issues are arising and relating to aging. And that's not just increase in life expectancy, but all these other factors as well, which is across Europe and globally, reduction in welfare support, changes in family structure, so increasing mobility within families, people living further away, lots of distance carers. We've talked a little bit about increasing female labour market participation, so women are often working in paid work, but also still required and assumed to take on most of the unpaid caring responsibilities, particularly of older people. And then around issues sort of more particular to the UK because of Brexit, we are experiencing chronic care workforce shortages, and that's really something that is a fairly new, obviously because of Brexit, fairly new phenomena. It's always been a sort of sector that has suffered badly with high staff turnover and low retention, low pay, lack of unionisation, all sorts of things happening. And then to add Brexit to the mix has had quite a negative, huge ramifications on the paid workforce, which obviously then impacts on the individual unpaid carers. So it's all of these issues, all of these factors to varying degrees relate to what has been coined unmet need and wellbeing failures by many sociologists, social gerontologists, care theorists, all sorts of different academic disciplines that recognise that there is severe unmet need and there is severe wellbeing failures across the board. And my research really is looking at a specific aspect of these wellbeing failures, and that relate to social care markets. And there's an increasing focus on understanding how the care crisis is relating to social care markets. So what do we mean by social care markets? So unlike, the NHS is situated under one free at the point of delivery provider, we know that social care markets within the UK are very fragmented. They're delivered within what is understood to be quite a mixed economy of care, but predominantly private profit-making organisations. And this kind of model, a market-based logic of social care delivery, is being increasingly sort of criticised and understood to not be working really for everyone involved in care, often referenced with evidence of care providers, private care providers, having to hand back contracts to commissioning bodies, often the local authorities, because of the issues mentioned above, often care workforce shortages. So governments and stakeholders alike are seeking alternative models of care provision within social care markets, and ones that promote the wellbeing outcomes for all involved in care. So unpaid care is included, as well as people who are paid carers. So my research is located in Wales, which is interesting for lots of reasons. I know most of the people here today are in Wales, living and working in Wales. So we have the highest number of unpaid carers across the UK. So we have 10.5% of people in the UK provide some amount of care, and that compares to England, which is 8.9%. And interestingly and importantly, we also have a higher proportion of people in the UK, in Wales, than in the rest of the UK, that are caring for more than 50 hours. So that's 3.6 compared to 2.7% in England. So we know that the correlation between poorer wellbeing outcomes and there's a correlation between those poorer wellbeing outcomes and the increasing number of hours of care, and often increasing number of hours of care go hand in hand with people caring for people living with dementia. It's more intensive, and it results in a higher number of hours that you're actually spending caring than other types of caring. So we have a higher number of people providing those types of care, that type of care in Wales than in the rest of the UK. And it's also interesting context, I think, to work on care, because we have a specific policy context within Wales in relation to care, and that comes under the rebalancing care agenda, the government strategy to respond to all the previous issues mentioned in the previous slide relating to the care crisis. And it's also considered to be a particularly permissive policy context for social care markets to be thriving in terms of these alternative models of care providers, these social enterprise organisations that my work is focused on. And Section 16 of the Social Services and Wellbeing Act contains within it a clause that means that local authorities, when they are commissioning and carrying out their duties to promote wellbeing of all, must support the development of cooperatives and social enterprises within their footprint, within their local authority footprint, to provide care and support in the community. So that's a really important piece of legislation within Wales that means that, in theory, we should have quite a thriving, interesting mix of care provision with that sort of emphasis on the social enterprise and the cooperative or community sector. And social enterprise organisations are defined very broadly. It's very tricky to sort of pin it down. because there's lots of different legal, there are a number of different ways that an organisation can sort of come under the broad term of social enterprise. But really they are businesses with a social or environmental purpose, and they carry out activities carried out for the benefit of society. They're also a really interesting organisation to understand and look at from the perspective of the policy agenda in Wales, because we also have a huge emphasis, as you know, many of you will know, on co-production. And that's broadly understanding that it's service users or people benefiting from care and support must be involved in the development of that care and support. So within section 16, we have that emphasis on developing cooperatives and social enterprises, and also the emphasis and expectation that co-production will be embedded within ways of working. So just to sort of linger a little bit longer on co-production in care services, the social enterprise organisations are considered well placed to develop and deliver services in a co-productive way. And we know that co-production is a key concept within care policy, and that's not just in Wales, but across the UK. And there are certainly, it's certainly something that's embedded broadly within policy, but it's also something that can have a variety of different conceptualizations. And I've put up some references there if people wanted to follow up. And often the different conceptualizations are reflective of the different traditions or disciplinary lenses through which it's being studied. Common to most understandings is the idea of citizens involved in the design and delivery of public services. So a very basic understanding of what co-production means. But by looking and surveying the literature, it's quite, it's broadly acknowledged, but there's little research on the outcomes of co-production or how to measure it. So we know that social enterprise organisations are considered to be well positioned to deliver care services in a co-productive way, but we know broadly that co-production doesn't actually, it can be very difficult to measure, and it's very difficult to pinpoint the outcomes of co-production. So my research is trying to bring these sorts of two aspects of the rebalancing care agenda together. And I think it's really helpful now to sort of pause and just sort of take stock, because the work can be quite difficult to sort of understand at a broad level. So my research is situated within the care crisis and looking at these alternative ways of responding to the care crisis within Wales, and looking at these alternative care models. And my research is sort of located at the intersection between family carers, social care markets, and this social enterprise organisation. And I set out to explore within a pilot study to begin with, the contribution of social enterprise organisations to carer well-being and carers of people with living with dementia, and understand where or why social enterprise organisations flourish or indeed fail in supporting carers. And I think it can be helpful to understand the project as beginning within operating within what's called the Care Diamond by Razavi. And this really understands the different actors involved in unpaid care and care markets. So there's obviously the government or the state, and they are a provider of welfare, and they are also a significant decision maker about who assumes responsibilities by the other three sets of institutions, who are the markets, the community, and the unpaid carer. So the market, I've put these figures here, and these are figures from Association Directors of Social Services in Wales. And they've provided figures of how much domiciliary care is provided by each of these sections. So 12% is provided by local or local authority sort of commissioned local authority teams that deliver 12% of the total number of hours of domiciliary care. Third sector provide 33%, and then the majority, as we can see, is 86%, and they are private sector providers, so they're private profit-making organisations. But by far the biggest contributor to social care in Wales and the UK more broadly is obviously the unpaid carer, and Carers Wales put that figure at 8.1 billion. And this project, my project, is focused on understanding how all of these different organisations work together, but particularly the community sector organisations and the family carer. So I think that's a really sort of helpful way of sort of understanding how this DISC project actually has been kind of theorised from the outset. So now we'll turn into the methodology and how the project broadly sort of worked and was designed. So it began with a theoretically driven analytical framework informed by a scoping review of the literature. And from the literature review, I identified a specific type of care theory called care ethics. And care ethicists such as Joan Tronto put forward the idea of care as a political, inherently political concept and activity, and that it was really something that without understanding care as political, we would never be able to get to fair care in democracy or fair care in democracy. And I thought that the care ethics approach was particularly suitable for this study because social enterprise organisations are obviously focused on generating social benefit and social capital. And they're a clear contender for the sort of caring institutions that Joan Tronto and other organisations talk so much about. Without these caring institutions, we can't have a caring democracy that works for all. So this particular type of theoretical approach to care informed my purposeful sampling, and I carried out 4 focus groups alongside the Dementia Hub, and this comprised of organisations within social enterprise organisations, so the paid staff and volunteers, and then 2 unpaid carer groups, LGBTQ+ group, and an older male carers group. So after undertaking the focus groups, I undertook a thematic analysis, which used the stages set out by Braun and Clark, and that helped generate the themes of capacity, competition, and findings. So using all of this together, I came up the final, just to turn now to the findings of the scoping review. So, and then I'll talk about the findings from the primary data. So based upon the initial findings of the scoping review on empirical studies that had working in this area, there's a sort of growing body of research that's looking at alternative models and social enterprise organisations. And broadly speaking, social enterprise organisations are considered to offer something unique to the social care landscape. So they are distinctive, considered to be distinctive, but not entirely sure how. And there's certainly very little research that's looking at how they are distinctive or what's the alternative offer for unpaid carers themselves. They're considered and have shown to be rooted within the local community, so they're very much able to be agile and respond to local emerging needs. They display and can show social capital and benefit, and there's some research that has been carried out in Scotland in the past few years that show that social enterprise organisations are contributing to challenging structural determinants of health. And they can offer this distinct response and are often assumed to be better positioned than for-profit organisations to deliver better caring outcomes. And then another research project carried out by Kelly Hall and Chloe Alexander in England in 2020-23 showed that social enterprise organisations were operating as what they termed anchor organisations. So they were providing peer support, community support in a sort of more of an upstream way. So they weren't necessarily providing direct care support, but they were more acting as this anchor organisation for local communities and for local community care related groups. But based on all these studies and the broader literature, there are gaps in our understandings and problems in how we measure the contribution of social enterprise organisations to caring outcomes. And there's some questions around the assumption of co-production and co-production practice. So based on this sort of scoping review of the literature, understanding what other studies have carried out and the findings of other studies, I took all of these findings on board and then presented into the findings from the DISC pilot study, which I'll now present to you. So these were based on the focus groups, which I carried out with the Dementia Hub. And these are the key themes that were generated. So competition, expertise, and co-production. And competition relates to silo working, and I'll go into some more detail. There was expertise, lots of expertise within the sector, understanding the sort of very heterogeneous nature of care and need. And there was also this key theme that emerged from my research as well, around capacity for co-production. And I will talk a little bit more about that as well in the next few slides. So just turning to, I think, the first theme, which is competition. So I'm just going to show you, bring up some of the quotes from the focus groups, anonymized quotes. But broadly, limited budgets and sustainability of funding was a repeated theme amongst the focus groups of providers. So they were stating how demand for their services often outstripped supply, but they were often unable to collaborate or poor resources, and there were issues around being able to work together with the broader sector to sort of tackle this increasing demand for support. And this quote here, I think, summarises that. So that's one of the problems with the third sector, and it's no fault of our own. We're pitted against each other from the beginning, and we all see each other as competition for numbers, or for the money, or for the client group. So that competition was a common thread, and I think pitted against each other for the numbers really does sort of summarise and crystallise that. There was also a sub-theme identified which returned to protectionism and parochialism, which obviously relate to this previous quote. And there's some sort of reflection on how difficult it can be to work with other people because of this sort of context of competition, and that it can be very, I guess the final quote really sums it up, that it's horrible and it's exhausting. So we found as well that some people were describing burnout, so the negative sort of context in which it can be really difficult to work in these environments. And we're not just interested in safeguarding the well-being of the people who are receiving care and the unpaid carers, but also the well-being of those involved in delivering that care and support. And for some people, it can be really a negative environment. And this, again, was referred to as it's horrible and it's exhausting. So I'll just now turn to the third theme, which was capacity for co-production, just in terms of time. I think that would be, so capacity for co-production was the final theme. And it was thought through working with one of the groups of carers that I think this finding was really sort of was identified. And subsequently, we've really tried to emphasise it within the follow-up project, which I'll turn to in a moment. So this capacity for co-production came through working through an equality, diversity and inclusion lens, I suppose, which is one of the key theoretical sort of anchor points of an ethics of care approach, is understanding the needs for inclusivity in care. And when I was talking and carrying out the focus group with the LGBTQ+ group, some of the group sort of emphasised that co-production can be actually really tricky for some organisations, particularly if they're trying to co-produce with these groups of underrepresented carers, such as themselves. And they really reflected on that and said, well, the co-production requires the local authority, the big authority, to let the third sector deliver. So that's acknowledging what we were sort of hearing from the literature and elsewhere, that there's an assumption that it has to be, or the third sector is better positioned to work in a co-productive way. But what they were actually stating was that they're not sure whether they had the knowledge. They might have the intention, but they don't necessarily have some of the sort of expertise or specific knowledge and skills to be able to do that with some specific groups such as themselves. And then they went on to say, but that's okay almost, because we're used to it. We're used to not being featuring, and we're used to being invisible. So I was really struck by working with these groups, because it helped to emphasize and sort of illuminate where there was some sort of, I think, particular blind spots or assumptions being made about co-production in care. So this theme has been carried through now into the fellowship that I've received to carry on this work for 3 years. But before I sort of go on to the fellowship, I'll just sort of final slide on the discussion on the findings from the pilot, which has been developed into a paper with my co-author, Abby. So just to summarise then, the potential of organisations to actually work in a sort of responsive way sometimes, and in an individual way and a unique way, is sometimes curtailed because of the sort of local and national broader care market, and some of the sub-themes relating to capacity and resources and the broader idea of competition really came through. So there was a lot of information based on how social enterprises can make sense of these local contexts and be able to respond how they would like to respond. And sometimes that was severely curtailed because of these sort of contexts which result in a huge amount of competition between organisations. Organisations definitely that we spoke to demonstrated expertise, dynamicism and innovation in everything that they were doing, working with unpaid carers. And that was shown in how that they developed specific resources for underrepresented groups of carers and specific programmes of support. And I think what's really important about the pilot project is that we engage with the different stakeholders, so both the beneficiaries, so the unpaid carers, and also the providers, which led us to be able to ask some really important questions, which again have been incorporated into the bigger study, in who defines the social value created by these organisations. So that's the unique feature. Any profit that's made by social enterprise organisations goes back into a social benefit, but who defines what that social benefit is? How do we measure it? And whose voices are missing perhaps from how that definition is made? There's a couple of just final points here about questioning the assumption that organisations are a default for co-productive support. So we definitely had that come through in the capacity for co-production issue theme. And then finally, the study limitations here. It was an exploratory study, it was a pilot study, so it's not generalisable. There was a small sample size and there was no comparator, which leads me now to happily say that I was funded to do a follow-on project, the DISC2, what it's called now, which is a 3-year fellowship award, and it's mixed methods, and it's been informed by this pilot study. It's funded by Healthcare Research Wales under their Social Care Fellowship scheme, and it runs, it's been running from October last year, that should be 23, until October 2026. So I've already sort of 9 months into the project. And the research aims are stated here. So the research will ask if and how the sector, the social enterprise sector in Wales, is delivering co-produced support for family carers, so very broad. And then what measures can be used to evidence the impact of these social enterprises, support on unpaid carers and social care systems. So there's an emphasis on measuring the impact and co-production. So over the next 3 years, I'm going to be doing the following, and this is year 1. So establishment of a research advisory group, which has met, and the research advisory group provide guidance and advice to the programme and will help disseminate and also help with impact. I've carried out analysis of local and national policy reports, and I'm about to and would like some input into a survey which I will be distributing across local authorities to map the quantity and nature of the sector working with unpaid carers. And then year 2, which will start this October, will be the qualitative piece, the data gathering. Primary data will be collected through a series of focus groups and interviews within a purpose sample of 4 study areas in Wales. And these have been identified as Powys, Bridgend, Swansea, and Gwynedd and Mons. If there's anyone in the webinar now who's from those areas, I'd love to hear from you. So please do get in touch. So just a final sort of slide on the potential theoretical and practical implications of the work. So obviously, impact is really, really important to me personally, but also as a funder, Healthcare Research Wales really want to see how their research that they fund actually makes a benefit towards the organisations themselves, but also unpaid carers. So there's a academic contribution of the work will be on theorising what it is social enterprises are doing in the long-term care context. There's definitely a huge gap in a theorisation for social enterprise organisations in long-term care. And then in terms of practice and more of the policy impact, I think there's a key role that can be supported by this research in helping commissioners to develop the conditions in which social enterprise organisations can actually flourish. We've got some great, as I said earlier, permissive policy framework under Section 16 and the broader rebalancing care agenda. And now it's really that there's a need to understand the local enabling conditions. And I think this research could play a role in helping that. Support the organisations who are delivering support to identify their potential blind spots or some inclusive co-production practices working with underrepresented groups of carers. And then the research will result in co-designed research to support organisations to actually evidence their impact. So we're talking about the measurement and how do we actually show the results and show the results that mean that future funding can follow, which is really what it's all about, is trying to speak to the funders as well as how to evidence what is quite a very difficult a context, and also evidence something which is very difficult to put into some of the funders' boxes. So there's a lot of work that needs to happen there. So my research will be helping to support that. So just a call out really to anyone who's on the call, on the webinar and wants to get involved. These are some of the ways in which you could. So obviously it's just an open invitation to contact me, please, and to discuss anything about what I've said today. If you're interested or you want to be involved or you think you could benefit, particularly interested in hearing in any organisations, any social enterprises who are involved with unpaid carers, please do get in touch. I'd love to hear from you, and I will be sending out a survey to try and get some input, but also there'll be qualitative research carried out where I can do semi-structured interviews and focus groups with organisations, maintaining anonymity and confidentiality, obviously, at all times. Really would love it if people would be involved in piloting the survey, because I really want that to be sort of something of use and help to organisations and individuals. So if anyone's interested in helping with the survey design and piloting, and also then sending out across your local authority and across your networks, that'd be fantastic. Please do get involved if you are coming from any of the areas, Powys, Bridgend, Swansea or Gwynedd Mon, because I've got funding and resources to carry out research within your area. So please do get in touch, because like I say, this research has to be of benefit in any way. So in ways as a provider and to unpaid carers in any way. So please do get in touch if you're from any of those areas. And then there's the final toolkit that will be produced with anyone involved in the research and who wants to be involved in co-producing the toolkit. So any ideas for dissemination and further impact, then again, please do get in touch. And that's all my sort of slides. I've got a few references here if anyone wants to follow up with any of the references, or email me, because they're not all up here, I'm afraid. So do get in touch if you wanted to have any more of those references that I've cited today.